understand why you feel this way, especially if you have felt this way fairly suddenly or recently, as opposed to having had a long-standing feeling that you were not the right gender for your body. It's really important that you don't get into doing something that may be harmful to your body until you're absolutely certain that this is the only path or the best path for you. And that may take quite a long time to work out.
Wrong Speak is proudly brought to you by Quillette, a platform for free thought since 2015, which you can find at Quillette.com. That's QUILLETTE. Contributors include Toby Young, Michael Shermer, Jeffrey Miller, Brian Boutwell, Kathy Young, founder Claire Lehman, plus Wrong Speak hosts Jonathan Kay and me, Debra So. Quillette promotes journalism that's free from orthodoxy of any stripe. If you like Wrong Speak, you'll love Quillette. I'm Dr. Debra So, and this is Wrong Speak, the podcast about the things we believe to be true but cannot say. As some of you may remember, our third episode of Wrong Speak was about rapid onset gender dysphoria, the growing phenomenon of adolescent girls and young women who declare that they are transgender, often out of the blue. In that episode, I had the opportunity to speak with Dr. Susan Bradley. She's a world-renowned expert on gender dysphoria in children, a professor emeritus in the Department of Psychiatry at the University of Toronto, and the former psychiatrist-in-chief at Toronto's Hospital for Sick Children. She is also the founder of the former Gender Identity Clinic at the Centre for Addiction and Mental Health that was shuttered in 2015. I spoke with Dr. Bradley from her home in Northern Ontario, Canada, earlier this year. Based on your feedback, we've decided to play the full interview as today's episode. In this conversation, we talk about the link between gender dysphoria and sexual orientation, the incidence of psychiatric comorbidity, including autism and depression, in girls presenting with rapid onset gender dysphoria, and what transgender activists have gotten wrong about this issue. We also talk about Ken Zucker, who is the head of the aforementioned Gender Identity Clinic when it closed due to activist pressure in 2015. Since my interview with Dr. Bradley, the Center for Addiction and Mental Health has issued an apology to Zucker for his dismissal. And in August of this year, Lisa Littman, a physician and professor at Brown University, published the first academic study on rapid onset gender dysphoria. Her findings suggested that for some of these girls, being transgender is a form of social contagion. Due to activist pressure and public outrage, the study was quickly denounced as transphobic. Brown University subsequently pulled its press release for the study, and the scientific journal that published it announced it would be conducting a review of its content and methodology. As you can see, rapid onset gender dysphoria remains a contentious issue, and what's being lost in this debate is what's in the best interest of these children. How do we balance legitimate fears of discrimination against transgender people with what science says is the best path forward? To be clear, research has shown that transitioning can be beneficial for some people who experience gender dysphoria, and adult members of the trans community should be entitled to live their lives as they choose. My hope is that this conversation will offer a perspective that hasn't been adequately presented in the mainstream, especially for parents who may be going through a similar experience with their child. In recent years, I imagine the sex ratio of the patients you've been seeing has changed. So in the research literature, a study from 2015 showed that while the majority of these children presenting with gender dysphoria were born male, more recently, since, say, 2006, we're seeing more females coming into the clinic. So children who were born female who identify as male. What do you think is driving this change?
In my opinion, it's the adolescents who are born female who come into puberty and begin to believe that they are the wrong gender. That's the group that seem to be tipping the scales towards more female-born children coming to clinic.
Why do you think that trend has been happening more recently?
Well, previously, we were not very oriented to the fact that a significant proportion of children in the gender dysphoria clinic had underlying autism spectrum traits. More recently, we've been much more alert to that as a possible factor. And in fact, when I see these teens coming with a concern about gender dysphoria, the teens who are born female and wanting to be male, I do a very careful assessment as to whether or not there's an earlier history that would suggest that they're in the autism spectrum. And it's been my experience that nearly all of them are. Nothing's ever 100%, but certainly my sense of it is that that's a factor. We also know that these teens are much more vulnerable than other teens. Teens who have traits in the autism spectrum tend to be very vulnerable individuals. The history is often one of having not fit in with their peer group, having been bullied or rejected, and when they become adolescent, they're really feeling very uncomfortable with themselves. Their self-esteem is not good. They often get depressed. Some of them may end up with body image disorders. Some of them end up with eating disorders. And now quite a number of them are ending up with gender dysphoria. The issue is that they seem to be very liable to be influenced by the media, which most teens are, but this group in particular, who are needing to feel wanted and accepted, have a much greater likelihood that they're going to be accepted by the trans community, who is quite open about saying, if you feel this way, you must be this way. And I think that's having an impact on this shift that we're seeing.
So when you speak of autism, what kind of tools do you use to assess whether these children meet the criteria for a diagnosis?
Well, there are a number of different tools, none of which are perfect. There are screening tools like the Social Responsiveness Scale and the Autism Diagnostic Inventory, but fundamentally it's a clinical diagnosis when you get right down to it, and it is a spectrum, and that's what's important, because there are some people at the very high end of the spectrum who are like Bill Gates and Albert Einstein and Marie Curie, who have done amazing things and would have no obvious disability, except that probably they might have been hard to live with, it would be my guess. But now that we're beginning to look at kids who are certainly at the higher end of the spectrum, we're getting a much better understanding of how many children out there may be impacted by having these traits. Diagnostically, we have a set of criteria, and you have to meet the criteria, but there's nothing that says exactly where the cutoff is on these criteria. And so there can always be argument about whether, we're overdiagnosing or not. But the issue for me as a clinician at this point is that if we identify those individuals who are struggling with social understanding, which is part of the core of this autism spectrum traits, we are better positioned to help that child manage the transition through their lives. If we fail to understand that they are having trouble in that way, then they go along and they are frequently having difficulty being accepted by peers, getting along with peers, getting in trouble with teachers because they don't listen or don't understand that the teacher is somebody that you listen to. And so their lives become much more complicated as a result. But by being able to identify these difficulties, and whether you agree about it being a diagnosis or just traits or part of a spectrum, the point of all of this is that we can tell better how to support these kids, and that's really the issue. And that's where when I start talking about identifying these traits in these adolescents who present with gender dysphoria, I really want to be clear whether they've had a previous history of having what we call repetitive or obsessive interests in certain things. And because once some of these kids fix on an idea, they can become really quite obsessed by that idea. And I've had some parents who, once I've asked about all of this, and they'll say, well, sure, they were into Pokemon and they were into a variety of other things, but it went away after a while. And that's part of what we need to understand and also help them understand, is this something that is a little bit like some of the things that you get obsessed with, or is this something that's going to be necessary for the rest of your life? And when you look at the stories of some of the people who have changed their minds later on, a lot of them are saying very strongly, I wish somebody had understood me from a psychological point of view and didn't just take at face value that I thought this was the answer to how I was feeling. The dilemma is that we didn't appreciate that this was an issue until probably 15 years ago. When we started the gender clinic in 1975, we had nothing really to go on in terms of understanding anything that may have contributed. There were only a very few studies that identified factors that might have contributed to some of the difficulties. At that time, I'd been quite active in terms of looking at some characteristics, specifically what we called then borderline personality traits. And I identified that some of the kids I thought had borderline personality traits. I had no experience seeing children who were high functioning but with autistic spectrum traits. The kids that I had seen in my training and even subsequently tended to be so visibly autistic that you didn't need me as a clinician to tell you that they had autism.
Could you give a few examples of borderline traits?
Well, what I was looking for at that point when I was using the terms borderline traits, there is a psychiatrist by the name of John Gunderson in New York who described borderline personality disorder, which is a disorder that we make a diagnosis of in adults, as having mini psychotic episodes. So they would have periods when their reality testing was not what we would consider normal. And those were some of the things that I, in fact, was seeing in these kids that I described as borderline traits. With hindsight now, and my experience looking at this population of kids who are in the spectrum, I think I missed the boat. And I really believe that those kids are probably, I hate to use the term 100%, but I believe that nearly all of the kids probably in these clinics have some autistic spectrum traits. And again, knowing the way this term is used, it can be very visible or it can be very hard to detect. And you have to do a fairly careful inventory of how that child responds to social situations, whether they've had difficulty understanding simple things like personal space, whether they misperceive situations such as if somebody touches them by accident, was that on purpose and were they pushing me? These are the kinds of things that I'm now very attuned to. And if I were doing this work all over again, that's what I would be looking for. So in answer to, is it 100% of the kids? I don't know. And what I believe now, and I'm not the only one who said this, is that probably people who get the label borderline personality disorder are people who are high functioning in the autism spectrum. That's where we're going conceptually now, because when you deal with a large population of kids, even the very high functioning kids in the autism spectrum, one of the most significant difficulties that they present with is what we call dysregulation. They have huge difficulty regulating themselves when they get either overstimulated or tired or frustrated that they're not getting what they want. And they have these meltdowns. That's one of the things. And even though it's not in the diagnostic categories or criteria, it isn't labeled as an essential factor. In my experience, it's the most essential factor in their development. And it's the factor that causes these kids the most difficulty because they get so dysregulated quickly, often over minor things, and they lack the ability to calm themselves down. And that's what we would have seen when we use terms like borderline personality disorder. So that's one of the similar things. And the other is this having periods where their reality testing seems unusual. Kids in the spectrum oftentimes will talk about things that simply aren't real, as though they're real. And, we know that it takes them longer to get their mind really clear about what reality really is. So it's easy to conceptualize these things as the same because we don't use the term really very much in children, which is borderline personality disorder. And there were a group of us who were muddling around doing this for a number of years. But I believe we were all wrong. I believe we're really talking about this trait. And you know what's important about this trait is that it's probably much more widespread in the general population. And I'll ask you all to just think a little bit about some people you may know whom you have said, that guy's an odd duck, or that girl's, she's always saying the wrong thing, or things like that. Like, these are traits that we are now very much more aware are more pervasive, and they're particularly pervasive in a highly educated population. So you get your university professors and you get people who have this ability to focus intensely on a topic of interest, but they're not very good socially. And so you see these kinds of traits. But, we don't make a big deal, and we don't go around labeling everybody with a psychiatric diagnosis. But the traits are there. And some of the studies, across different populations have suggested that whereas previously we were talking about 1% of the population may have autistic traits, in some studies where they've used a finer comb, they're picking up much higher percentages. And in the families of these kids who receive a diagnosis, 15 to 20% of the parents have those traits. So you can begin to see in certain groups of people that there may be really heavy loading for some of these traits. So to back up a bit, when you're saying that what was previously seen as borderline traits was actually potentially ASD or being on the spectrum. That's my thinking. Is that across the board in the field, or would you say that's specific to kids presenting with gender dysphoria? I would say that's probably across the board. However, the other sine qua non about borderline personality traits is that they have a history frequently of being sexually abused. And that is not uncommon in this population of what I'm going to describe as vulnerable adolescents, because these kids often, the kids who are in the autism spectrum, are more easily abused than kids who are not in the autism spectrum because they don't have the savvy to know when they're getting into some trouble. And one of the things that I often ask parents is, how good is your child at understanding stranger danger? And they'll look at you as though, they'll go and sit on a stranger's lap, and they'll do things like that. I mean, that's one of the kinds of things that makes them very vulnerable. And so this overlap between a higher level of sexual abuse may be partly because of their vulnerability and their difficulty with social understanding.
And how would that feed back to rapid onset gender dysphoria? Because this is something that is prevalent in females.
Well, what becomes important, at least in the population that I've been seeing, is that many of the, and at the time sometimes that I'm still seeing them, they still identify as female, some of them, will be able to say that they began to feel they were lesbian. That was how they would define themselves. And they felt uncomfortable. They, having had a history of feeling that they were not fitting in and different, when they start thinking of themselves in that way, that's another thing that says, I'm really weird. There's something wrong with me. And so a lot of these kids, when they go on the internet and find another possible solution, which is being trans, and people are welcoming them with open arms, it solves a number of problems for these kids. They have a group that accepts and respects them and says, you're okay. And it deals with that feeling of being homoerotic in their experiences, of feeling that they're attracted to girls at that point. And so that has been the common experience that I've heard. The only other thing that I've seen is some of these girls, before they are transitioning, have been sexually abused or threatened, and they feel that they're unable to protect themselves as females, and that's another spur to say, I would be better off as a male. I saw a young person many years ago who came to the clinic with an expressed wish to be male. And after we'd done our interview, it was really clear she had been sexually abused by a couple of boys, and she felt horrible about it, and she started to put on weight and started to change her appearance so that she was bigger and stronger, and she said, nobody would bother me now. And, you get these stories, and it's very hard to say, these sound logical in my mind. So there's a mixture of factors that I think are contributing to this increase in numbers of individuals transitioning to the male gender in early adolescence in this population of children or youth with autism spectrum.
So this is really interesting what you've been telling me. Why is it you think none of this has really been represented in the public conversation on this topic? Well,
we have literature in that has emerged from all of the clinics now looking more systematically using a variety of different screens and measures to try to understand how many of the current population might, in fact, fall in the autism spectrum. And, we're getting numbers like 50% and sometimes even more. And as I indicated earlier, the issue of making that diagnosis in these higher functioning individuals has a level of controversy about it. And so when a clinic assays their population using one tool or another tool, it isn't necessarily the defining number that we're going to be able to say, well, we're really talking about nearly all of the kids who come into the clinic. We're still picking away at, are there a small group who don't have these factors that may be contributing, who are the true trans, which many of the activists would insist there must be true trans out there. We're still struggling with trying to figure out, is there a true trans? And, when I first began working in this area, my feeling was there must be something physical. And we did all sorts of tests in those early days. We couldn't do as many as we could now, but we sure did a lot of things looking for something biological and could never find anything. And gradually, as we evolved in terms of our understanding, we ceased looking for a biological thing. Now, that doesn't mean it doesn't exist, and there are still differences if you look at adult populations between people who have transitioned and people who haven't in brain structure. Part of what is complicating this search for understanding is that if people engage in certain activities for a prolonged period of time, their brains change. We know that that's what learning is all about. And so when we look at brains of people who've gone through the transition, how much of what we're seeing is due to the fact that they've been doing things more like a male or more like a female for goodness knows how many years. And is that what we're measuring, or is there something else that's unique? It's hard to imagine that those minor differences that may be there are enough to cause what we're seeing in terms of a desire to be the other gender or sex. As scientists, nearly all of the people that I know who work in this area are very cautious about what they say. And that is in marked contrast to the position that the activists have taken, that there is no argument about what I believe. You can't, and that's what makes it hard to have a discussion.
And that there is a true trans.
Yes. And so we're humming and hawing about, well, there's no evidence that's clear. And they're saying, well, there has to be. And so this is where we get stuck. And they are speaking far more loudly than we are right now, and have caught the ear and the sensitivity of the broad population in terms of being politically correct. And so even Ken Zucker, who in my mind is the ultimate academic in this area, he still speaks very, very cautiously about everything he says. And he would probably say I'm over-speaking about some of these things, but, I'm a clinician. So, and, my belief is that these kids who are transitioning in adolescence probably will end up being lesbian or gay. And that our position for years in the clinic was, that's a good outcome. Let's try to make sure that they don't have to do surgery on their body. Both Dr. Zucker and I were on the intersex clinic at Sick Kids for a number of years, and so we had a chance to see a lot of these kids and to follow up some of them. There is a higher incidence of gender dysphoria in intersex individuals, but it isn't the majority of individuals at all. It's a very small proportion. And the ones that we saw actually in the clinic were not radically different in terms of the family kinds of variables from the kids that were not intersex. So it may be a factor, but it's a small factor. The group who are probably most vulnerable are the girls who have congenital adrenal hyperplasia. So they're born with exposure to a high level of testosterone in utero. And so they're often very masculinized when they're born. And in fact, sometimes it's difficult to know whether they should be raised as a male or a female because they may have such an elongated clitoris that it looks more like a penis. And some of those kids earlier were in fact raised as males. But amongst that group of children, that's the group who, if anybody is going to display gender dysphoria, it's likely in that group of girls, in my opinion.
Going back to what you were saying with a lot of these girls, so they're born female, they identify as male, but they likely are lesbian, and a better outcome would be for them to grow comfortable in their birth sex. Well, how do people react when you say something like that?
Well, the parents are somewhat relieved because I think a lot of the worry that parents of these kids have is that they're now hearing more about the negative effects of even puberty blockers, and certainly the fact that once they get onto anything that's irreversible, such as testosterone and obviously surgery, there's little turning back, and that's the worry that most parents have. And when they've heard stories of people who've changed their mind after they've gone through all of this, that's really scary for most parents. The trans community does not like to hear that because they feel that we're not being accepting enough of transgender feelings and wishes. And so this is where we come apart a little bit. We have always been willing, if kids have worked with us in the clinic, to try to be sure that they know what they're doing, that they're on the right track, that there is no other solution for them other than going forward with transitioning. We would support their going forward. I mean, there's never been any question. It's the going forward suddenly when you haven't looked at any of those variables and you're getting into something that is irreversible. That's what has always made us concerned, and is certainly, as a parent, would make most parents concerned.
Do you worry that any of this information could be used to justify transphobia?
Well, it's always a bit of an issue in terms of anybody who's different. There will always be stigma associated. It doesn't matter whether it's with a mental health diagnosis or something like transsexualism. I don't see a real way around it. Right now, there's a lot of acceptance of trans individuals in our culture, and I know that makes a lot of these young people feel much more accepted. However, does that mean it's a good thing for them or not? That's the big question.
And going back to the role of social media, how has that influenced the cases that you see? Well,
there's all sorts of social media, as you know, and what has, from my perspective, been most concerning is that there are trans support groups out there which don't necessarily understand that people may be leaping into the fire too soon. Like, they don't understand the vulnerability of some of these individuals. And so by simply saying, well, if you think you're trans, you must be trans, that may not help that individual. And they have trouble understanding that being accepting could in any way make it harder for that person to make a reasonable judgment about what's good for them. And so that's what I worry about. And even some of the groups that these kids will go to, if the group is open and allows kids to say, well, I can be this or I can be that, what's wrong with this? We would want them to hear a number of different voices. We would want them to talk to people who are gay and lesbian and say, well, I felt that way sometimes when I was young, and I just realized that I didn't have to be that way. We've got to get all of the voices able to speak so that these young people can make a reasonable decision about what's good for them. I have an example, if you'll bear with me, tell you a story of a boy who came to us at the gender clinic when he was 7 or 8. He'd had a history of neglect and inadequate parenting and had become a ward of the Children's Aid. And he was expressing wishes to be a girl that had started when he was probably 7 or 8, somewhere in that range. He was seen by the clinic, and we followed him over the years. And as it turned out, I happened to consult to a clinic in the small community where he was living, and followed him to some extent through the staff who were seeing him there, because the clinic that I'm working with is a mixture of child welfare and children's mental health. And that group runs an LGBTQW group now. The W is for whatever, I understand. And they've been running this group now for quite a long time, and this young person was an active participant in that group. And he had really gone some distance by age 14 or 15 in the transition to being female, and was accepted by most of the people that he was working with there, the child welfare staff as well as the clinical staff, that this was what he wanted, and what seemed to be good for him. And he continued in the group, which has this mixture of kids who are different in various ways. He found somebody that he was very attracted to, another male, and they got into a relationship. And after a period of time, he announced to everybody that he was no longer trans. He was quite happy being gay. He was in a relationship with somebody whom he loved and who respected and loved him. And thank you very much. That was all he needed. And so when you see some of these live stories, you realize that so much of this issue is between the LGBT group. There's a lot of fluidity, or within that group, there's a lot of fluidity. And by foreclosing on the identity of any of these people too soon, we may be doing them a disservice. That's really the gist of my story.
How old was he when he desisted?
About 15 or 16 when he finally decided that, I don't need to transition anymore.
Can you talk a bit about the relationship between sexual orientation and gender identity? Because I think the idea that the public tends to see is that these are two completely separate things. But within the field, there's an understanding that they're linked.
They're clearly, in my mind, linked. If you follow up the population of kids from various clinics through their adolescence, what you find is that the majority of kids who have decided not to transition are gay or lesbian. There are some who are straight, but this proportion is relatively smaller. So we've always had the assumption that these individuals are more likely to move along a trajectory of being homosexual than straight. However, and even some people from within the gay community, really, some of the people who work in the adult clinic have really, I think, said, this is ridiculous. I mean, if I look back on my experience as a gay man when I was young, many of my friends played with dolls, did a lot of these things, but we didn't have to go beyond that. And it raises real issues about the culture in which we live, which is, if you have a culture in which being trans is more high profile, and even maybe more respectable, I hesitate to say it that way, but wouldn't you rather decide you're going to become trans than just be an ordinary homosexual person? Like, that's part of the dilemma that I think we're dealing with.
How does homophobia fit into this?
Well, I thought we were getting better around homophobia, and I think, given where we were 50 years ago, we're clearly better. But it's such a persistent factor in all societies, I think, that it's very hard to dismiss its impact on young people. I mean, they're at the most vulnerable part of their lives as sexual beings, and when they encounter this sense that there's something odd or different about me in terms of who I love, it's got to be a factor which says, maybe I'd be better off being trans, because that's normal in their notion. If I'm the other gender, then who I love is normal.
Heterosexual.
Yeah.
What are the parents like of the patients that you see?
Well, I should begin this by saying that the parents of most individuals in the autism spectrum, and I'm in the midst of writing a book on this because I'm worried about the parents perceiving themselves as the problem when they find that they have a child in the spectrum. Most of these parents are pretty ordinary, good parents. I mean, there are certainly, they're no different than your broad spectrum of parents. There may be a higher level, as I said earlier, of some autistic traits in those parents, but they're not necessarily different than your average kids whom we would see coming into clinics. They, for the most part, early on, most of them were not very positive about the idea of kids going through gender transitioning. Certainly, more parents now are more positive about this, and I see it as some of the pressure that they're getting from the trans community about being accepting. Some of them have had a very difficult time knowing what to do when they've decided that this doesn't make sense to them. The parents are often very confused about the situation. Some of them cannot accept that this makes any sense at all, and because they've seen the history in their child of these intense, repetitive, and obsessive kinds of interests before, and they believe that this is just another one of those same intense, repetitive interests. But they also feel that they have to be accepting of their child, because that's the message out there, that you can't let your child down. And a lot of them are faced with messages, some from the trans community, that if you don't accept your child, they're going to go out and commit suicide, or they're going to get very depressed. And so you have to be accepting of them. And so they're caught between a rock and a hard place in terms of what do I really do now? Because I think this doesn't make sense, but I don't want my child to commit suicide. And these adolescents in the spectrum are very vulnerable to getting depressed, to cutting behaviors, and to suicidal behaviors. So we're talking about something that they may already have some familiarity with, because they've seen their child at other times get really quite down. And so a lot of them are really not knowing just what to do. Some of the recent fourth wave messaging that's coming out, I think, has been helpful to some of them, because they're being able to hear other parents who are equally confused and concerned about proceeding with simple acceptance. And so they're trying to figure out, is there something else that I could do that's going to be better for my child than simply going along with things? You know, the data isn't wonderful. There's a small amount of data that suggests that those who transition feel less depressed and not as suicidal. The problem with it, though, is that we don't have enough long-term follow-up to know whether that's a rather short-term feeling, because these people are vulnerable, and so they don't handle stress very well. And going through any of this is a pretty stressful thing to do. And so we need more data. We know that if you look at a population of these kids before they transition, a lot of them are expressing depression, suicidal feelings, things like that. There appears to be some lessening, but whether that's a real thing or not is up for grabs.
When you're referring to fourth wave, are you referring to the blog for parents?
Yes. Full stop.
Can you elaborate a bit on what?
Well, a number of parents who have had these concerns about their children who have this rapid onset gender dysphoria have been able to voice what appear to be sensible concerns that a lot of parents can relate to, and it's acting as almost a support group for those parents who feel that a lot of professionals that they turn to are not actually understanding their concerns as much as they are accepting their child for whatever it is they're requesting.
And the parents you see, how did they align themselves politically? Would they tend to be more left-leaning, more right-leaning?
Oh, that would be a really hard thing to ask. I've seen them from all kinds of backgrounds. There doesn't seem to be anything one way or the other.
Do you mind me asking how you identify?
Pretty left-wing. Okay.
And with regards to how you approach therapy then, would you say your colleagues approach in the same way in terms of trying to understand if there's comorbidity there, what's actually driving the gender dysphoria, as opposed to taking a child's wishes at face value?
Well, the colleagues that I'm closest to, and also I think to some extent the clinics that we've worked with in other parts of the world, take a very balanced view. The Dutch were perhaps more, if you can call it, progressive in terms of affirming kids when they wanted to transition, but they've also been fairly cautious as well. Our position all the way along at the clinic before it closed was that we have to understand these kids as well as we can before we encourage any movement that is not reversible. And, you know, even the puberty blockers, I was kind of cavalier about it early on because we were reassured that there were no long-term side effects. More recently, both endocrinologists and pediatricians are starting to say there are long-term side effects from the puberty blockers. And that's made me feel we've got to be even more cautious and make sure that we're doing the right thing before we send these kids off to medical kinds of interventions. Unfortunately, a lot of the clinics that have now sprung up don't appear to be well supported from a psychological or psychiatric point of view. And so they are appearing to take the adolescent's statement about what they want at face value much more readily, with much less intensive assessment of how that child is feeling or why they would want to do that. And the parents, in some of these situations, have not even been allowed much opportunity to voice their concerns. I've spoken with some of them who are really frustrated because they didn't get a chance to talk to anybody. You know, it's such a complex dilemma for families to face that even whether you believe in true trans or not, it's a big deal for a family and for parents, and they need a lot of support, and they didn't feel they were getting it.
When you talk about the clinic closing, are you referring to Ken Zuckers' clinic in 2015?
Yep.
For our listeners who may not have followed that story, can you summarize it?
Well, the clinic that I started in 1975 was at the Clark Institute of Psychiatry, the then Clark Institute of Psychiatry, which became the Center for Addiction and Mental Health. And that's the clinic that was closed after a very brief and inadequate external review. And Dr. Zucker was head of that for probably 25 years after. And when I left that clinic and went to Sick Kids, he took over as the head of the clinic. And from my perspective, I've used this term before, he is the leading academic in this area. And it's an awful pity that he can't continue his work. That's the sad thing.
How has the clinic closing affected the way that other clinicians approach kids with gender dysphoria?
Well, I think it silenced a lot of people who might have felt that these kids deserved a more intensive assessment or more support and things like that. A lot of people have said that they're afraid to speak out about it. The other clinics, the one in Ottawa and the one that was at Sick Kids, and the clinic in Toronto, Sherbourne, I mean, they have appeared, at least to me, to accept at face value an individual statement rather than doing what we would regard as a proper psychiatric and psychological assessment of the child and family.
They're afraid of losing their jobs.
They are.
So why is it you aren't afraid?
Because I'm retired and old. They can't do very much to me. So that's life.
Where do you see these girls ending up? So these girls who are presenting with rapid onset gender dysphoria, where are they going to be in 10, 15 years?
You know, I think some of them are going to change their mind, and that's the worrying thing. Some of them will go ahead and probably find their niche and be okay. But I worry about the ones who change their mind. That's because they can't get their life back in a way that's going to be necessarily adequate for them. And hearing the stories of the ones who change their mind is quite heartbreaking.
So of the kids who detransition, then what is life like for them once they do detransition? You
know, we don't have the data. All we hear are these stories online or personal anecdotes. But some of them are quite angry that the system was sloppy and didn't meet their needs from a psychological point of view and help them understand that this was something in their mind, not in their body. And so I think they have a right to question that. But what we can do about it, at this point, I don't know. I mean, the numbers are growing, and that's the thing that becomes even more worrying.
As a clinician, then, how do you weigh the fact that majority of these children will desist, but there is a chance that some will persist, and that if they do and they reach puberty and if they undergo the effects of puberty, that transitioning will be more difficult for them?
That's a real issue, and that's why people urge support early with the medical changes, but we're weighing how much harm are we doing, and our first part of the Hippocratic Oath is do no harm, and that's sort of gotten lost in this thing where people are getting on the bandwagon in a way that they're accepting the idea of transitioning where there is no clear evidence. You know, now, I mean, medicine values the notion that we provide evidence-based treatments. This is an area where there's no evidence-based treatment going on. There's no evidence for the lack of harm or the benefit of the transitioning process, except that some people say it saved their life or they're much happier. But we don't know enough about the whole lot of them. You know, the early studies that followed up people who had transitioned, say, 20 years ago, they were people who had been gender dysphoric for a very long time before they moved into the process of transitioning. They weren't like the rapid onset girls where things are happening so quickly with very little effort. And so we may have a population where there's a much higher level of desistance after transitioning than we did in the earlier studies. So it's going to be very hard to sort out where the best path is for all these individuals.
For the girls with rapid onset, How quickly do their symptoms show up in terms of what you've seen?
Pretty quickly, in my view. Kids will sit on the feeling that they may be gay or lesbian, sometimes for a year or two. But a lot of the kids are more open about that than they might have been. At least they're open with peers. And once they start being more open about it, they're starting also to get more involved in social media. And that's where the process seems to really get going.
Why do you think there's such a bias in terms of the media coverage and what's being presented on the topic of gender dysphoria in kids?
We are, as an essentially liberal culture, really struggling with being politically correct. Some of us care less about that, but a lot of us care a lot about that. And so that being politically correct, I think, has taken on such a large part of how we talk and think and what we say that we're unable, I think, to say the truth as we see it or feel it at times. We have to watch what we're saying.
Can you speak a bit to how prepubescent children are considered different or separate from adolescents and adults when it comes to transitioning?
Well, the prepubescent group that we've got data on, we now know from studies in several of the different clinics, tend to desist by the time they're teens in large numbers. So in some studies, it's 90% of them stop wanting to be the other gender. Some, it's lower. But that population where they're being encouraged to transition early, we are particularly concerned about, because it means that for a lot of these kids, once they have gone along from age 5 to 10, believing that this is who I really am, that process of allowing them the headspace to say, well, maybe I'm not that, and to think about it, is probably not going to happen very well. And it's hard for kids who are in the autism spectrum to do what we call self-reflection anyway. And so for these kids, it's doubly hard to change their mind. They can get really intense in their beliefs about things. And so with that young population, it really doesn't seem fair or logical from a psychiatric or psychological point of view to encourage early transition. Where it becomes a lot more complicated is with the teens, because now with their emerging sexuality, a lot of them feel intense pressure to bring some kind of closure to who they are and what they want to be and who's going to be their friends or their lovers. And so it's a different dilemma, and far more pressing. Many of these kids, when they would come into the clinic, were so intense that you can certainly understand the parents' concerns about suicide, because you see this young person who has a history anyway of being fairly intense and oftentimes quite angry and upset when they can't have what they want. Then being told that they have to slow down and think about this and make sure they're doing the right thing. That's a complicated thing to expect of them. But that's what we have to try to achieve in order to be fair to them and make sure that they're properly treated. When we see kids who are 15, 16, and this is the issue of, puberty blockers versus not, because if they've gone through a full puberty and, in the case of males, have facial hair and all of that, you can understand their frustration and dilemma about our saying, well, are you sure this is the right thing for you? Because they feel even more weird and different at that point. However, I have followed some teens and young adults, and I now have a person whom I saw when I was a resident and have followed, and he is now 60-something. And he had been unable to have the surgery earlier because Ontario wasn't offering phalloplasty. And he recently went down to the U.S. and had it. And you can tell from, we email back and forth all the time, he's just feeling so much better. Now, this is where there are some things that we know make a person feel more whole, and having a body that they look at every day that convinces them I'm okay is part of that feeling okay. But, we also know that it isn't just your body. Some of it's in your mind. And if you feel that you're not so good, or you're not liked by others, or you're always screwing up socially or things like that, that may not necessarily go away. So even though you may transition, some of these other things are still there. And that's where some of these people who are detransitioning are starting to say, well, you didn't fix that, or that didn't fix that, that didn't make that go away. So it's partly helping people understand what this transitioning can really do for them and what it can't do. And, talking to people like Ray Blanchard at from the adult clinic, his concern was that for a lot of these people, they kept on seeking more and more surgery to make them more perfect or more right. And the surgery wasn't going to do it. That was the underlying problem. So even in the adults where, we've watched these people take a long time and they're still there, who go through all of this, some of them still are not all that happy about what's happened to them. One of the things that I've seen that makes a difference is if a person, and this is so whether they're gay or lesbian or trans, if they can get into a relationship with somebody who accepts them for who they are, regardless, then oftentimes the other things don't matter all that much. And this individual that I was telling you about, who at age 60 finally got to have the phalloplasty, he lost his wife. And he was absolutely devastated when she died. And it was after all of that he felt he had to pursue the surgery. And, for me, had his wife lived, they were a good couple, and you hear that and see that with a lot of people. It's gay and lesbian people as well as trans people. So a lot of what's going to make a person happy is their ability to get into a relationship that's good for them and that makes them feel loved and valued. And even the studies, that we would do, like the early follow-up studies on outcomes from transitioning, they were cross-sectional. Like they sat you down for an hour or 2 hours or something like that, asked you all the main questions, and you didn't tell them, I've still got a pain in my heart. Like some of these kinds of things don't get revealed until you know that person well enough that you would really hear that this didn't solve some of the problems that you hoped it was going to solve. And that's the bottom line.
How would you describe your approach to therapy when working with these kids?
Well, it's really listening to try to figure out what is going on in that person's psyche that makes them feel that the solution that they seem to be saying they've found is the best solution. So I would be wanting to ask them, have you ever thought of something else? Have you, like with some of these rapid onset girls, I've been able to say to them, well, you can be a butch lesbian, like what's wrong with that? And they've looked at me and said, yeah. And so offering up different options that we want them to at least think about. They don't have to accept my view, but I want to hear what's going on for them. And I want them to know that there are many different options. This group that I was talking about, I really feel is invaluable, because by exposing trans kids to kids who are LGB, they're hearing different voices of lived experience, and they can hear that, well, they chose that, so why did you choose that instead of something else? Like, that's what they need to be hearing. And I think in some ways it's better if they hear it from peers than it is from somebody old like me. So I'm not working in this area really anymore. I consult, and I will offer help to staff who are dealing with them, but really it's the trying to get them thinking about what they're doing, why that's important, and what are other options that they may need to understand. It's also, because some of these kids are depressed, trying to make sure that you've done what you can about the depression and the suicidal thinking. Some of them benefit from cognitive behavioral therapy, where they're really supported in thinking differently about how their feelings, managing their feelings better generally.
And what advice would you give parents who say their child does come home from school one day and says that they identify as the opposite sex?
Well, I think the parent has to ask questions like, how long have you been thinking that you feel that way, or what makes you want to feel that way? You can't shut down the conversation. You have to keep the conversation open so that the child can use you and keep talking with you. And then if you can find a therapist who can help in that process, both with the parent and with the child, that is the kind of thing that I think is helpful. And not somebody who's got their mind shut to this being the solution and that's all there is to it, but that there may be many different solutions.
Have you experienced backlash for the things that you've said publicly, or for the op-ed that you wrote for the National Post?
Yes.
What does that look like?
Well, that I don't know what I'm talking about.
So they'll say that to you?
Lots of silly things.
And you're not on social media, are you?
I'm not, no. And, in fairness, I am very uncomfortable about being on all these things, because I don't have the time, and I don't want to get into doing this stuff. I've got better things I can do with my remaining years.
If there's someone in our audience listening right now who is trans, what advice would you give to them?
My advice is that it's really important that you understand why you feel this way, especially if you have felt this way fairly suddenly or recently, as opposed to having had a long-standing feeling that you were not the right gender for your body. But it's really important that you don't get into doing something that may be harmful to your body until you're absolutely certain that this is the only path or the best path for you. And that may take quite a long time to work out. I think people, if they can be in a group with other people who have differing points of view, or see a therapist who's broad-minded and will help them be sure about what they're doing, that's the best advice I have.
Thanks so much for chatting with me.
You're welcome. I've enjoyed it.
Thanks again to Quillette for supporting this episode of Wrong Speak. Be sure to visit Quillette.com, that's QUILLETTE, for commentary on science, technology, culture, politics, and all the other things we love discussing here at Wrong Speak.